Okay, well, hello everyone. Thank you again for joining the Superior Health Quality Alliance Roundtable conversation. My name's Kim Heft, and I am joined by actually not a few, but many of my colleagues, as well as our guest speakers today. We have Tracy Radke and Rachel Dibble. We host these 1-hour sessions on the second and fourth Wednesday of the month. The first half is didactic, and then the remaining time will be set aside for question and answers. Now, the PowerPoint presentation link will be dropped into chat momentarily. I ask you to use that chat box to share your comments, questions, anything that pops into your mind during the presentation, and then we'll use that for discussion in our Q&A. We will also put an evaluation link in chat afterwards that we hope that you'll take the time to complete. It takes probably about 30 seconds to a minute to complete. We appreciate that. Now, today's presentation is the second of a two-part series on improving diabetes management in long-term care. Now, last week, we learned about the effects of diabetes on seniors in our communities. Today, we're going to focus on improving resident outcomes through our interdisciplinary team and best practices in transitions of care. Before we get started, I do have the two announcements. My first question to all of you is, do you know if your team has a low power or high power distance culture? Maybe some of you don't even know exactly what that is. Well, if you join us on, I shouldn't say if, when you join us on November 8th, that's our next event. Tabitha Myers, she's going to be educating us on power distance in your organization. We're going to have role-playing activities and tools for your team to achieve what you want to achieve is a low power distance culture. So we'll see you then. Lastly, how are all of you doing with getting your residents and your staff vaccinated with the latest 2023-2024 COVID vaccine? With a show of like thumbs up or drop it in chat, who has had a COVID vaccination clinic? Do we have anybody out there that has had one thus far? Thumbs up, put it in chat. Thumbs up, put it in chat. Oh man.
I see somebody in the chat, Kim.
Good, thank you. Thank you. I didn't catch it. Excellent. I have had a clinic. Most all residents received it, not many staff. Just had ours delivered from pharmacy this week. Not yet, but we're working on it. Oh, excellent. This is great. Has anyone besides their own pharmacy had someone else come in to do this for you, like a partner pharmacy, not necessarily, again, your pharmacy, but maybe you had to do outreach to a local pharmacy, someone of that nature? Anybody have that? Good value came in. Good value. What state is this? Michigan, Minnesota, or Wisconsin? Wisconsin. Okay. Alicia, is this a, do they have a mobile clinic or just pharmacy? Okay. All right. Okay. As you can see, we are looking for, okay, our local health department is scheduled to complete our clinic on Tuesday. Amy, is that Wisconsin? Michigan, Health Department, Michigan. Okay. All right.
Health Department, Amy, just in case there's anybody else on the call that's your area and they're looking.
Just asking that.
Oceana County. Okay. Perfect. Yeah. Oh my gosh. Thank you so much for all this, because as we are, working with all of you and all these nursing homes, we're finding that some of your peers are having a difficult time. setting up clinics to get staff and residents vaccinated for COVID. So this helps. If you can give us information like this to pass on to your peers to get their residents and staff vaccinated, we appreciate this. Yeah, keep them coming. If you know of anybody else or you've heard of mobile clinics coming in, we would love to have that information so we can help others too. But we do, though, if you are looking for a clinic, we do have some options. So Elaine is going to drop in chat our email address, immunizations@superiorhealthqa.org, because we do have some free clinic mobile services for you. They might not fit all your needs, we're not sure, but that's why you need to email us and we'll see if we can help you. And we've been pretty darn successful in getting many, many nursing homes and the residents and staff vaccinated. So, so please utilize us and each other.
And I just want to correct my own self. I put immunization in that first one. It should be immunizations with an S. Apologize.
Perfect. Okay. Well, that's all I have for my announcement. So we are going to get started with our presentation. And I welcome Tracy Radke to the floor.
Well, thank you, Kim, and I'm glad and appreciate all of you that were able to join us today. Today, again, our focus is on diabetes, moving beyond and improving resident outcomes. Our objectives today are to identify barriers and strategies in treating patients with diabetes in long-term care, to recognize the importance of an interdisciplinary team in diabetes care, and lastly, to identify key best practices and transitions in care on patient outcomes. So before we kick off into the content, I'm sorry, Kim, did I miss something?
Not at all. I think I'm a little gun happy here with my clippers. So you go right ahead, Tracy. Go right ahead.
All right. Well, now, before we jump into my content, I wanted to have a polling question. So, Kim, if you would launch the question, you can choose multiple items. It's not a one and done. So please, as many of you as possible, if you would click on those that are a part of your IDT, if you have one.
Hey, they're coming in. They're coming in.
Yes, loving it.
Okay.
The more, the better. We're up to 12. Keep coming.
Very nice.
Your vote matters.
Your vote matters.
Every vote counts.
Every vote counts. Okay, I'm going to end the poll and we'll share these results.
Excellent. Wow. Okay.
Did we get anything for other?
Yes. If there is an other, please put that in the chat. We'd love to hear about it.
Did we miss anyone? Do you have anybody on your IDT that was not on this list? We'd like to know. All right, well, while people are thinking if that is true, we'll just move on with the presentation.
All right. Thank you for that feedback. So,
wait, we got an activity director.
Oh, I thought of adding them and didn't. Dang it.
You know what? That is so true. An activity director. You know how many snacks and food items
and the physical activity of doing some of these activities. So excellent.
We have an IPC nurse therapy. Oh man, these are great.
Excellent.
Yeah, I couldn't think of everybody. Nice. Okay, I'm sorry, I didn't mean to interrupt, but we got a couple of
No.
additions there.
And you are welcome to enter questions in the chat throughout. I am not opposed to stopping and answering them unless it's something that maybe is coming up further in a slide. So, okay, so now moving on to talk about the barriers of caring for patients with diabetes in long-term care settings. So the best treatment plan, therapy, cannot prevent the progression of the disease in any person. And along with that disease comes a lot of additional complications. So there's added risks through to multiple systems in the body, which just adds to more complexity in treating the disease. There are multiple different what we call geriatric syndromes, or the giants of geriatrics, which are immobility, instability, incontinence, and intellectual impairment. So these can result in falls, fractures, dementia and depression, cancer, malnutrition. Of course, we mentioned the incontinence. So that all adds again to the complexity. There are also different processes that within the setting that can cause their own unique barriers. And then the goals for diabetes management at the end of life, they need to focus on promoting comfort, controlling any distressing symptoms, which include pain. They may say, I no longer want to take my insulin. I no longer want to take any of my oral medications. And it's, important to respect their rights to refuse that treatment. So that can be a struggle for some because your nature is to treat. And then just the overall stress of trying to keep these patients healthy can add to the stress level can also cause struggles. Next slide. So the strategies to improve diabetes management. So things have changed. Before it was all about carb counting, and that may be true for younger adults, but for this population especially, liberal diet plans have been associated with improvements in both food and beverage intake for older adults. This helps avoid dehydration and unintentional weight loss because usually at this age, we're trying to make sure they maintain their weight. So avoiding those restrictive therapeutic diets, you want to try and stay away from that. Historically, diabetic diets that were prescribed for older were prescribed in long-term care settings. And there's growing evidence that these diets may inadvertently lead to decreased food intake and weight loss, undernutrition, which is the opposite of what we want. So in response to this, nursing homes have shifted away from these diets and offering a wider variety of food choices, trying to address personal food preferences, and just giving a variety of dining options in regarding to the time, the type of meals. So while carb counting should be taken into consideration, it shouldn't be no concentrated sugars or no sweets. Hypoglycemia risk is probably the most important factor in determining that each patient's glycemic goals. Due to the catastrophic consequences in older adults. You want to establish goals of care and management strategies for an individual in a long-term care setting. And this requires acknowledgement that there that each individual has their own complexity in terms of stage of disease, complications, comorbidities, their self-care ability, life expectancy, and just the risk of adverse drug events. Lastly, we don't want to limit glycemic control to just insulin, and make that treatment, and don't make the treatment too complicated. Try to keep it simple and safe. Next slide. So the interdisciplinary team members, and you all voted, and I love the ones that were added. I think they all bring a unique perspective to the team. But I want to also ask you, is your team all it can be? Is it a strong team? Do you feel like there's good collaboration, good communication? Are each member's views and input respected? And if not, how can you make it better? Are you getting, because a physician dealing with all these complexities that we just talked about can't do it alone. Every person at the table has a unique set of skills and knowledge to contribute to the care of that patient. So make sure, if not already, that leadership is demonstrating the importance of this by providing budget resources, maybe even establishing some expectations, and then developing maybe an institutional respect in the culture for handoffs and requiring buy-in for all disciplines. Next slide. So how do we want to leverage this team to get all we can? And again, stating the obvious, that no one person has the full knowledge of what can help this patient, right? Because of the different complexities. So leveraging it is establish and involve the team in developing, implementing, and maintaining effective focused diabetes care. So have you established a good program for how you're going to treat patients with diabetes? And you should use this team also to define what is each person's role and expectations to the team. And this includes designating someone to oversee and lead that team, and making sure that everyone is represented that should be and is involved in both transitions in care as well as transitions in work, meaning handoffs internally and externally. We want to utilize the team in developing a structured, tailored, and multifaceted approach. So again, you need every voice at the table to see all sides of the disease and to overcome whatever barriers are out there to enhance the use of appropriate protocols in the care of your residents. The team should engage staff and guide diabetes care that includes the leadership, physicians, nursing, even frontline staff should be involved. Have champions out on the floor that can help be ears to the ground on what's happening and what maybe can be improved. There are multiple other ways you can leverage, but these are the key ones I wanted to point out today. Next slide. So benefits. Communication is key, and it doesn't matter what you're trying to do, what you're trying to improve or implement. There's got to be good, clear communication and coordination of care within the facility. So when all the stakeholders are present at an IDT meeting, other issues can come up. It's just like your safety huddles. If you have those morning safety huddles, what your knowledge is, if you share it, may be beneficial to someone else. The same is true in these team meetings. This assists in preventing negative outcomes and preventing care and ongoing treatment. This is a collaborative approach for best practice outcomes because we don't want to treat this patient in silos. We are a team. It takes a village. It's one of my favorite lines. So some of these benefits are blood pressure management, lipid level reductions, improving their quality of life. The social worker, they're seeing more of that aspect of it, their mental health. Activities is seeing maybe some of removing some of that depression through involving them in different activities that they enjoy. MDs, NPs, and PA nurses, podiatrists, endocrinologists have all been shown to reduce the risk of amputation of lower extremities by as much as 34 to 47%. That is huge. Another benefit is that they can help significantly reduce the risk of end-stage renal disease in patients with type 2 nephropathy and significantly reduce the risk of mortality compared with non-integrated care. So working collaboratively fosters those supportive relationships. It builds strong and committed organizational teams and leadership. And it produces that clear and open communication with teams. There's trust. There's relationship where you're going to be more open to sharing your goals, your approaches to their treatment. And the importance of a team is to discuss this patient from head to toe, looking at the whole body, not just one disease. Next slide. So now we're going to transition into transitions of care. Next slide. So some of the foundational effects of transition of care are the transitional teams. Part of this transition of care work is measuring and tracking data. Anyone in quality should know that unless I measure, how do I know I'm making an improvement, or how do I know what I want for an outcome is actually the outcome? It assists in comprehensive discharge planning. Medication management is huge, no matter what transition you're doing. Hospital to nursing home to home, nursing home to assisted living. Those medications, it is so easy. And we thought with the use of an EMR, a lot of that would change because we no longer have to rely on reading a doctor's prescription or writing in a chart, but it actually opened up a whole new set of potential errors. So it's really important that that pharmacist and physician and any other players on the opposite side receiving that patient are aware of what is that patient actually taking. Patient and family engagement and education is huge because they need to participate in their care and understand what their care needs are. And that includes whether they need to be transferred. Sometimes patients and families feel my mother needs to be in a hospital when that's only going to add to potential problems, and that actually the care they're receiving there is right and appropriate, and their parent is doing well. Staff education, also very important. And we get back to this communication, right? In transitions of care, So important. And then finally, coordination of care. Next slide. So I did some research. I was really trying to find what are the best practices, what have been shown in studies or retrospective reviews on, what should be included in a great transition of care from a nursing home back home, let's say, or a nursing home to home with health care. And there really hasn't been any, which is really disappointing. And some of this I know is due to the complexity of this patient population that studies don't want to really work with. Anyway, so the best I could do was find what are some of these quality care outcomes that can happen following transition of care interventions for older people when they go from the hospital to home, because there is a lot of crossover. Next slide. Hospital transition and care best practice that you should expect at your facility. And this also includes the hospital side or anywhere. Some of this is really important for all sides. And again, getting back to that med rec, that process includes communicating to the pharmacy. You want to confirm that they have received the same orders that are listed in that discharge paperwork. You want to make sure there is a safe transition of patients with representation across the facility. So again, getting back to that interdisciplinary team, they all need to be involved and meet on a routine basis when it comes to preparing for a discharge. Again, back to measuring and tracking, you want to have a process in place that you're reviewing and analyzing data on a regular basis and learn and find opportunities for improvement when it comes to transition. And that might mean finding out, it might be calling the patient. Maybe they end up in the hospital and you're not aware. So other ways to get the information. And make sure there's a section on that transfer record devoted to communicating that patient's preferences, priorities, goals, and values. And this is big with CMS in regards to health equity and social determinants of health. How important it is to keep that patient's perspective and preferences and culture of life and playing a part in that discharge to the next, whether it be home or assisted living, let's say. Keeping that older adults' belief systems in the forefront and respected is important. Next slide. So quality care outcomes following transitional care interventions for older people from the hospital. And again, this was a study that I looked through, and the key findings were that comprehensive discharge planning, which again can only happen if we have everyone involved in it, complete and timely communication of information, again, medication reconciliation, and you want to, and I guess I'm asking you, have you ever sat in on a discussion between the nurse and a resident during discharge? Because this is an opportunity for education and to improve the discharge planning, and teach back is huge. So again, keeping the patient at the forefront and their input in the discharge. And again, another study proving that open communication is important between all providers and caregivers, and prompt follow-up. And this is more on the hospital side, but it does not mean that when the nursing home is discharging them home, that it is important to make that phone call and find out how they're doing. So we want to, if if maybe it's important to make sure they have a visit with their primary doctor, then we want to do that. Make that phone call, do a soft handoff. All of that only improves the outcomes for that patient. Next slide. Transferring from home to home health care, home with home health care. And this was, I interviewed a woman who has spent many years in leadership with a home healthcare organization. And this is the information she thought was most beneficial. Up-to-date health records, so accurate med list and doses, their immunization list, also important. Last labs and the results, last doctor appointment, or if they were seen outside the nursing home. And is the patient a new diabetic? Because that will impact education and other types of care services. And is the patient able to manage their disease? And are they able to check their blood sugars? Are they taking their med? How have you assessed whether they can take their medications or give insulin injections? And then what are the patient and caregiver educational needs? And then lastly, any complications that they may have, such as wounds healing or numbness. Maybe it could be muscle weakness or imbalance. All of those types of complications are helpful. Next slide. So after our last session with Rachel, who, by the way, did a phenomenal job, there were several questions, or not several, but at least two questions regarding insulin and the sliding scale. So I am going to turn it over to Rachel in a few minutes, and she will go through the sliding scale, and we will open it up for any questions that you may have. Next slide. So hyperglycemia protocols in the nursing homes. Protocols, and again, this goes back to the importance of having like a diabetes champion who knows what is the process when we've identified that somebody has hypoglycemia or hyperglycemia. And those having those in place, it's like the quick action team, that you send out. They know what needs to be done and do it quickly. This is helpful because the sooner you can resolve the problem, the better for the resident and the outcomes. There's a journal, the Journal of American Medical Directors Association studied a program where nursing homes took a 3-part approach to train and educate staff, residents, and loved ones on managing disease. And as a result of this, the episodes of hypoglycemia were resolved in roughly 75 to 90% of the cases without any follow-up problems, thanks to the nursing home staff that participated in the program. So champions, and just like sepsis care, you want to, the quicker you get the medication, the antibiotic drip going, the quicker it is, the better the outcome. And then here's a link to download pocket cards from the for diabetes education from the ADA. So I want to ask, how many carbs? Well, actually, I think I'll since this is more about the hyperglycemia and medications, I am going to turn it over to Rachel for the next slide. Current literature and management of diabetes and long-term care. Rachel, take it over.
Thank you so much, Tracy, and for all the information. So there, as we all know, within the literature and recommendations, evidence-based, and then what then a recommendation may be from an association or any of the journal articles, etc. They've really landed on a recommendation It is based in evidence, but have they done away with the sliding scale? They haven't done away with it totally. So, so that's the answer to the question. And then I'll go into a little bit of what their aim was into making it a little bit more customized, if you will. So current literature and management of diabetes and long-term care patients. So several organizations, they have developed the diabetes guidelines for patients living in long-term care. I'll also say hospitals as well, a lot of the hospital associations. And almost all of these guidelines emphasize, and this is very true, individualizing care goals and treatments related to diabetes. Of course, you have different acuity levels, different treatment options, regimens, etc. And then avoiding, this is where it gets into the kind of the slippery slope. So it's avoiding sliding scale insulin or SSI as a primary. So that's the key word, primary, means of regulating glucose. And what the regs are saying now, like I said, we're not doing away with it. So this has been a 40-year lift for the organizations to try to come across and get some data together to really change the guideline altogether. But it's complicated, as we know. So basically, the aim of all of it was that they were the incidences of hyper and hypoglycemia in long-term care in hospitals was really way high. So in figuring this out, when they go back and look at the guideline, everyone's on the sliding scale. And that's someone who's 90 who hasn't eaten in 3 days, and that's someone who's 40 who's in there with pneumonia. So it was like, it was, you know, one-stop shop fits all. Well, we know that doesn't work. So they've come to this as well. So their push is really, it's a culture change. And this has been a 40-year situation, apparently. I was surprised to find this out myself when I did some reading about it. So so that is the aim, to prevent the hyper and hypo, and that each patient looks differently. Moreover, when they look in 3 categories of insulin and trying to mitigate some of the sliding scale habit that we have, it would be is to give basal insulins instead. And the key is being proactive. So with the sliding scale, that equals to being reactive. Are they high or low, and let's adjust. So that whole thought is being thrown away. Let's be proactive and just regulate their sugars to begin with, because their diets are different. They're not exercising. They may be on corticosteroids, which makes your glucose goes up. There's all sorts of things, infection, all sorts of things that can, you know, that necessarily is not just a sliding scale insulin situation. So they have come to conclude that basal insulin rather, nutritional insulin, and correctional insulin are the 3 buckets of which they're looking at insofar as sliding scale. So the takeaway is, sliding scale is still out there. The recommendations, though, from these associations and these governing bodies are, it really is not good for the patient. It hurts the patient, and they really are pushing to avoid sliding scale. A lot of this is education, as we know. It's a culture change, the whole sliding scale idea. And so the importance of providing adequate training and protocols to long-term staff who may be operating without the presence of a practitioner for a prolonged period of time. So just educating some of the clinical staff rather, or anyone else for that matter, of just the mind shift. And we are seeing this in healthcare a lot these days of culture changes, and it takes a long time to get these things moving. We talk about it for 20 years and then it happens. But we can make that change, and we can start spreading that word, communicating it, collaborating it with it. What do you think? What are your thoughts? You know, I've got this patient over here. What do you do? You know, we can learn from each other. And this is one of those areas. It'd be interesting to see what some of your colleagues also visit your policies within your facility.
So Rachel, if a patient, you know, let's say they're type 1 and they're on insulin, can they benefit from taking an oral medication?
Type 1 is, and Kim, you have some more experience with type 1, but my experience with it is that it is insulin typically on them, that regulates, automatically takes blood sugar and just gives insulin as needed. So that's not, because it's monitored per the monitor rather, it's not really it's somewhat reactive, but it's in real time reactive, right? So if someone hasn't been there for 5 hours, we haven't checked a blood glucose, they haven't eaten, they're on a vent, and we're using a sliding scale. And maybe they don't have TPN, they don't have food, tube feedings, they don't have anything. And often we see that. Maybe they just have fluids for a couple of days, but we're still doing a sliding scale on these folks. And maybe they don't even have diabetes, but they're on corticosteroids. So their glucose is way high. And then we bottom them out because we've just given them some insulin when they didn't even need it. They were hyperglycemic related to disease process opposed to diabetes. So that's why all of these things now, finally, they're starting to look at like what's really appropriate for the patient in what situation and in what setting. To have read about this and researched it, I appreciate that. That's why I love questions. We all learn so much from each other.
Which is what we're
Tracy.
going to move into next.
Tracy, just real quick here. I just want to make sure I understood some of the question right. Did you say that could a type 1 diabetic benefit from an oral diabetic agent?
Yes.
Correct?
Yes.
At least as far as I know. Now, again, I'm not to say all of everything, but the type 1 diabetic, and this is where I felt the nurses in the nursing home sometimes got this a little bit confused. If your patient is a type 1 diabetic, an oral medication is not going to benefit them in any way because their pancreas does not produce insulin. It has been shut off. It will never produce another insulin cell ever, ever, ever. So if you give them a pill that, and correct me if I'm wrong, Rachel, the pills are to enhance insulin that's already being produced or to make it better. Sometimes insulin is mutant. It doesn't work right. So we give oral agents, diabetic agents, to help make insulin better. A type 1 diabetic can't make insulin. You can give them pills every day of the week and it ain't going to do anything because there's no insulin to enhance.
Right.
And that's how I like to tell the nurses that I've worked with in long-term care when they're trying to understand the differences between their two patients.
Yeah. Type 1 beta cells have gone to heaven. They are not coming back. Beta cells are not coming back. Oral does nothing.
Yeah, I thought that was a good question to pose because
Nice.
sometimes we think multi-therapy can be beneficial, but not in all cases.
So quick question, just because we're on the subject of being proactive, and I really love that conversation. So if you have somebody who is in your facility, especially we know that we have a younger population that's coming into facilities now, and they are on the pre-diabetic scope, should we start to monitor at that point versus being reactive if they cross over to be a diabetic?
Great question.
I'm happy to answer, or someone else can if they'd like.
Go ahead, Rachel.
At 100%. I mean, the cutoff is 126 for fasting glucose, meaning when you go in and get blood work done, if it's 126, you are diabetic. If it is 124, 125, 120, right there, we are looking at, and now it is pre-diabetes. And so we have to be proactive right there. And typically, depending on the provider, they may say, okay, diet and exercise, come visit me with strict monitoring. Some will say, let's go ahead and start you on metformin. Let's start a low dose, which is also helps lose weight. That's not the indication for it, but it does. And let's work on your A1C and glucose, then diet and exercise lifestyle later. And then that is one approach. And then the next approach is no matter what, that person has pre-diabetes, they most probably have some hypertension and maybe some obesity and some other things going on. So then all of those things need to be addressed as well. So it is the second we are pre-diabetic, diabetic, we are proactive, and that is the big shift. Yeah.
Yes, yes. Yes, and that's what I see on the clinic side, that if somebody, that very same strategy, because there was a time when they were pre-diabetes, it was kind of like, well, see me in a year.
Yeah.
But that things have changed,
Yeah.
and so you want to immediately take some interventions, because the earlier you do, the longer you can put off the progression of the disease. So it just depends on what your numbers are, and sometimes it can even be the physician's approach on the way they want to address it, but it is not ignored. That is for sure.
Absolutely.
Okay, yeah, so now we are in our open discussion. More questions. I love it. Ask away. It doesn't have to be what's on the screen here.
I think, and I'll say one more thing about pre-diabetes, because I think that's also kind of the, in healthcare, things wax and wane, fabulous, and it's not the actual recommendation, but they've been, dancing around it for 10 years or whatever it is. So, about 20 years ago, there was not a diagnosis of pre-diabetes, or 25 years ago. I mean, I would have teachers say, it's like you're pregnant or you're not. There's no that's it. And that's changed. And I appreciate that, because that helps us to be more proactive in the world of inching up to save your kidneys and your heart and your vascular system.
Mm-hmm.
I got myself on mute. I know there's, well, I know we have these questions here too. I can go back. Let me just show you one thing.
Oh yeah,
we have
the takeaways. Do we
I will,
show
yeah.
those?
I'll go back there in just a second. I just realized that there. These are tools and resources that are based around what we've been talking about, diabetes, care coordination, what have you, right? These are great for the session we have been talking about. I guess I'm emphasizing that just a little bit, because in chat, there are a couple of other resources that I wanted to point out. There was one in here earlier in regards to care transitions that can be used for any person, not just a person with diabetes. And just at the very end here, there are two resources on a root cause analysis and an action plan. These could be used, of course, these tools for anything, but and I think I did say this last week too, or 2 weeks ago, was using this tool for your diabetic residents. Where are the gaps? Where are you seeing your gaps in your processes? And, are you having a lot of hyperglycemic residents? Are you having a lot of hypoglycemic? Why? I have a tool right here for you to use to get down to your root cause. And then better yet, use the action plan tool to figure out what your plan is, do a PDSA cycle on it. And after you've analyzed your data, you probably will be surprised that once you've identified these issues, your patients with diabetes will live a much better and healthier life from avoiding like all those dips in their glycemic level. Just want to put that out there. And now I will just let you go back to your presentation. I know you wanted to go back to your takeaways.
Well, thank you, Kim. The more tools in your toolbox or tool belt, the better. So today's takeaways, well, not just today's, but from last week as well, is the importance and function of the interdisciplinary team, the effects that diabetes has on many major organs in the body. Pretty much it touches everything. So the biggies being the heart, circulatory system, the nervous system, which makes this disease very complex. The transitions in care are not easy, and it's a team sport. So it's dependent on not only internal communication and collaboration, but external. So building good relationships outside of the nursing home that can help improve the transition. And then communication is key. We've talked about how important this is in anything we do, but it helps build relationships with hospitals, home health agencies, and it really makes a difference in medication reconciliation and immunizations, which are really important for a diabetes patient. And then polypharmacy, and the more medications on board, the more chance for adverse drug events. And finally, tis the season to get immunized. So this means influenza, get that COVID booster. If you haven't had that pneumococcal vaccine, get it. And of course, there's boosters for DTaP and hepatitis. There's several. So all of these have significant benefit for a resident with diabetes. And those are the key takeaways. Any questions that you might have regarding the takeaways? Again, the resources. There is a 2023 update to the American Diabetes Association guidelines in diabetes care. They have pocket cards. I think you can get them for like $6, not a huge expense. But that information is out there too. I will turn it over to you, Kim.
Yes, actually, this was great. I have a couple minutes, and I'd like to go back to slide 16. Slide 16, yes. And this was so interesting to me, Tracy and Rachel, because about the participation of the study that the three-part approach to train and educate staff and residents on managing diabetes and the outcomes of this. And I honestly wish I had a little quiz to give all of you, because I didn't realize this as a little late. Not that we can't make one and put it in our arsenal of tricks for sure. But I do challenge you to go back to your nursing home and ask your staff, your licensed staff, your CNAs, maybe your residents, your families. It depends on how far you want to get with this. But I think good questions would be, I love the first one you had earlier, Tracy. That was the type 1 diabetic can benefit from an oral diabetic medication. Ask your nurses, when should a long-acting insulin be held? How many carbs should I give a hypoglycemic resident? Once I give a resident insulin, how quickly do they need to eat? And what kind of insulin would it be? I mean, which ones do they need to eat if they got Lantus? Not necessarily, but what if they get Humulin R? Yes, they do, right? My point here is do a pre-test. Go back, do a pre-test with a few questions, like 5, like pretty much like what I just said, and hand them out to your staff and see how many they get right or get wrong or whatever. There's a good way to identify, my staff doesn't quite understand what I need to do with my diabetic resident. That's why they're going hypoglycemic all the time. So there's just a good way to kind of measure how well your facility is doing in this area. Any other questions?
The last question I have really is around the safety huddle. For a facility who has not done a safety huddle, how do they get started with that? Is there resources?
So I'll take that. usually that's led by the administrator, and how you get started is talk about it. I don't know what types of, collaboratives or committee meetings you hold, but that's where you would want to structure it as to who should be present. But the key to this is it should be stand up and it should not take more than 15 minutes. Mm-hmm. It is a quick call out. It could be this, manager of environmental services saying, I've got a guy coming in, he'll be on unit such and such, replacing or doing work on the sprinkler head, whatever it is. And all of those things may seem little to some, but significant to others. So it's helpful for the team to know, okay, we're going to have a stranger coming on our unit. What do we need? Is there anything we need to be prepared for? But it is not a complication. It's maybe putting together a list of what would be considered patient safety related, or maybe you don't put any limits and it becomes not just safety, but it's a just that quick, let's get together, what's happening today. And then anything that takes more than a minute or so to do or resolve, then it's offline, because this is all about this is not for problem solving, this is for communicating. And then the problem solving happens offline.
Thank you. Well, I don't have any other questions. I don't see in chat or anything at the moment. I thank you. Thank you both, Rachel, excuse me, and Tracy for this good conversation. Yeah. I learned a lot. I hope others did too. I do. And I also thought, I thought of one good thing to tell all of you. We are going to be putting out the new invite for the 2024 calendar. And we have already been diligently figuring out what we're going to talk about, what our topics are going to be, things of that nature. So first of all, I would love to, in the evaluation today, if you have any suggestions for the 2024 season, I don't know if you want to call it season, year, to put that in there. But I also going to let you know, stay tuned, because we are in the progress of making a series on F tags. So we haven't picked out which ones we're going to talk about, but it's something that I think you'll all be very interested in, is certain different F tags that are cited often, or disease processes and other things that wrap around those. So more to come, more to come. So again, thank you, everyone. Thank you, Rachel. Thank you, Tracy. Thank you, everyone, for being here. And we'll see you again in a couple of weeks. Bye-bye.